Well, I think this is a good time to kind of get into some discussion about multifocal performance. Okay, we've kind of taken the monovision versus multifocal issue and talked about that. We've talked about setting some patient expectations. Unless there's anything else that anybody wants to say about that, I'd like to kind of get into a little bit more specifics at this point.
I just want to stress so everybody at this table agrees that their monovision is really something that's gone.
Mono's gone.
I'm going to say monovision has its place in the appropriate patient. It's in my tool belt, and I have a good, solid understanding of what it can and cannot do. And I will use it when I feel that it is truly, for that particular patient, the most appropriate option for what we have going on.
I don't take it off the table either. I agree, but it's not where I go.
But it's not my first line. I will always, for a normal patient with regular optics, it will be multifocals are my first line.
Absolutely,
okay. But it's not that I haven't forgotten how to fit monovision, and it's not completely out of my tool belt of options that I have. But it's not my first go-to.
My office may be a little bit different because my wife specializes in binocular vision. Mm-hmm. So if she's working in the vision therapy practice to give kids binocular vision and I'm in the next room taking it away from a presbyope, I get in trouble.
And you don't want that.
No.
And that's fair.
I know your wife.
And that's utterly fair. I mean, the truth is, to me, it's the last resort of trying to solve something when everything else you've tried has gone nowhere because the patient just is not adapting. But it's begrudgingly done. It's not, I know I'm not giving them their optimum thing, but it's still something that exists and has existed forever.
Are you prescribing driving glasses?
Yes, and that's the part that I find interesting because to me that's the key takeaway of how you know that monovision is not the optimal idea versus multifocal, is that you require a separate pair of glasses either for driving at night or for long-term reading, or things like that. If you're having to create a bunch of pairs of glasses to supplement the simple fact that you could have theoretically, in this worst case scenario, fit them just for far and given them reading glasses. So instead of them having contacts for far and one pair of reading glasses, even if they didn't adapt to multifocal, now they have 3 pairs of glasses to try and solve this because I put them in monovision. So I'm not really sure how I did them a service there, but it's still one of the paradigms.
Well, the biggest advantage of multifocals is both eyes distance, both eyes near, and intermediate vision. So you sort of have it all.
I think when you look at a multifocal lens, we have natural vision. I mean, you see distance, you see mid-distance, you see near. We also know that in some studies it shows that monovision at low light near may be a little bit better on some instances than multifocals, but then then you really have a problem with mid-distance because you've overplussed the near so much, you've given up the mid and the distance. So as far as advantage, it's like this. Multifocals are normal vision, monovision, and is an adaptation to a poor seeing.
Yes.
One of the other negative things that we haven't talked about since we were talking about evidence-based medicine is the effect that monovision has on the eye long term. And one of those changes is the development of additional anisoe between the eyes. Right. And so then you're driving the patient's refractive error by changing their contact lenses. And I don't know that that's the thing that I want to be doing is doing that. And there's evidence that backs that up. Obviously the benefits of multifocal lenses is full range of vision. Right. It may not be as super crisp, particularly in that low illumination, but you get the full range of vision and you don't have to worry about the patients on the road like you do with monovision patients.
You instruct them to turn on an extra light.
Yeah, I mean, yeah. It is the truth. It's, if you, the word, I mean, you just hit upon it, anisometropia, we're unnaturally changing things, we're unnaturally affecting versus the word natural vision with monovision. I mean, I'm sorry, with multifocal, natural vision with multifocal. Do we really want to go natural or unnatural in this situation? Do we want to preserve the binocularity that we can? Do we want to preserve the patient's prescriptions, and be able to follow them all the way through? Or continue to create the situation where we've got one short arm and one long arm?
You know, it's interesting when you present it to a patient, and if you give, say you want to give a patient an option, and you say, well, you know, we have two choices. We could do one eye distance and one eye near, you know, or we
And they
could
go.
do, and they actually,
Yeah,
exactly, they actually sort of back up and they go, why would I want to do that?
Job has always been and always will be to obtain binocularity whenever it's possible. I mean,
Absolutely.
That's what we do in every aspect of our practicing lives, and it shouldn't be any different. And maybe in the past, when we didn't have decent multifocal lenses, we didn't have much choice.
Right.
But we have a choice now, and the choice is pretty obvious, and I think even from
Yeah.
the group here it is.
You know, the other interesting thing is that we haven't talked about at all yet, but is the choices that we are working with our patients on right now are going to affect the choices that they make later in their life. And that's the after cataract surgery and what implant are they going to have? And are they going to do monovision? I know plenty of cataract surgeons out there that do monovision in the cataract or don't give the patient a choice